First session this afternoon is a panel discussion about advancing clinical practice, challenges and implementation, different ways of approaching advancing clinical practice. Let me introduce the panel. On my far right, we've got Dr. Steve Kennish, who's a busy cardiac consultant, diagnostic and interventional uroradiologist in Sheffield. Over the last 10 years, he's built up a uroradiology team from just 2 consultant radiologists and 4, so he's now got 4 consultant radiologists, an advanced ultrasound practitioner and 2 advanced radiographer practitioners, whilst in succession serving as uroradiology specialty lead, site lead, and now deputy clinical director. So a busy chap, but implementing advanced practice in intervention. So that's, we'll hear from Steve shortly. As we move along, we've got Emma. Emma's from Great Ormond Street. Emma Rose, she's an advanced practitioner in interventional radiology at Great Ormond Street Hospital for Children. She founded the extended role radiographer in interventional procedures special interest group after recognising the need for advanced and extended role radiographers performing procedures to form a peer network. So that's Emma. And then we've got Liz coming along, and Liz Van Lingen is an advanced practitioner in CT who's developed and leads on the cardiac CT service in Cornwall. Having spent many years in a team leader role, she uses her leadership and management skills to drive forward excellence and innovation in clinical practice. So welcome, Liz. And then we have Chrissy here. Chrissy is also from Cornwall, a consultant radiographer with 25 years of working in the NHS and over 10 years experience in plain film reporting, teaching and the patient pathway development. She enjoys supporting her peers to achieve their career goals and will always be full of admiration and gratefulness to patients and the education they offer. And then finally here we have Sarah. Sarah's a consultant sonographer, also at the Royal Cornwall Hospital. In her time away from work, she likes to explore the Cornish coastline with her family and dogs. She enjoys swimming, tennis, reading and travelling, and sitting around a virtual fire. So welcome all of you. And I'm going to let's kick off. Let's kick off with Steve and put the radiologist on the spot first. Let's do that. So how do you? I mean, we've heard you're really busy and you like to develop radiographers in their practice to join your team. How do you manage the competing time and resource demands for training advanced practitioners alongside radiologists?
Yeah, I think part of you've got to kind of turn things to your advantage, haven't you? And we're a hugely busy tertiary referral centre that's, I think, traditionally struggled to recruit enough staff in a number of different areas to keep up with the workload. So we're very specialised and we do a lot of a relatively narrow range of procedures. I think one of the advantages of the trainees being with you is that you can train them up to a high standard. You know, if you can train them up to competent level if that's a struggle. That's the aim, to try and get them to be competent. But with the on-call shifts and the night shifts and the time off in lieu with the European Working Time Directive, you can also use that to your advantage. So you've got huge amounts of work, lots of patients needing lots of procedures, and you've got the trainees with you, but you can plan ahead for when they're not with you. So that is the time then to get your advanced practitioners trained up. You've not got both of them competing for your time. You can give them that protected training time and get them up to the required level just through numbers and high quality training. And then everyone's happy. You have to get buy-in from everyone. You have to get everyone on board, really. And there's different ways of doing that. You can do it diplomatically. You can do it in a slightly underhand way if needs be, if that's in the best interest of the service and ultimately the patients. And trainees in radiology, radiology registrars often feel slightly threatened by advanced practitioners, radiographers. They feel as though they're perhaps encroaching on their turf or taking training time away from them, and that's something that you have to bear in mind with how you plan the training. So we maximise the amount of training for the advanced practitioner radiographers when the registrars were off, on compensatory leave. And to get buy-in from the registrar, we created a project to do, and we audited the numbers of patients that the registrar did, and the number of patients that the advanced radiographer practitioner did. And when they got the logbooks back, because we've got so much work, both of them had huge numbers of cases, which they were very proud to have taken part in. And we did a little presentation at the British Society of Interventional Radiology meeting, and it was called "When the Cat's Away, the Mice Will Play." And obviously, the cat being the radiology registrar, and the mouse, not just for that, being the advanced radiographer practitioner. And we proved that we had adequate workload, adequate numbers of patients to train up both professionals in a satisfactory way.
Excellent, thank you. I'm going to ask Liz next a bit about, we heard that you developed this cardiac CT advanced practice. What was the driver for change that got you going on this?
So the driver for change for us was the availability of skills to run and support the cardiac CT list. So as most of you are aware, I'm sure, cardiac CT lists are supervised by a consultant, and we had a talk, I think, earlier from Phil around the lack of skills to support those lists. So we knew we needed to support a certain amount of lists to maintain our position on the waiting list and prevent patient breaches, and to do that successfully we needed the consultants. But what we found was we didn't have those skills readily available, or if we did, we wouldn't have cross cover for things like sickness or annual leave. I'm sure you can all relate to the experience where you have to cancel lists last minute because of equipment breakdown, and we couldn't re-provide those lists because the consultant wasn't available, just because of the service demands on their time. And so 3 years ago we trained up 2 radiographers to supervise their own cardiac CT lists, and that was completely unsupervised. So the consultant isn't present within the department when we run those lists, and it's been a real success.
Brilliant.
Yeah.
Brilliant.
And it's offered that flexibility as well for us of when we can provide the lists. So.
Yeah. And Emma, tell us a bit about how you've developed the practice in, you're in a very specialist hospital doing intervention. What support systems have you had to see put in for advanced practitioners in that context?
So I think the most obvious one to start with, like Steve's alluded to, is a supportive consultant team. There currently isn't a course in interventional radiology for radiographers to go and learn something. So without that supportive training network, you're never going to learn how to do it. And it doesn't actually just include the doctors. The nursing team and the other radiographers taught me a lot as well. So they taught me how to scrub, they taught me how to do sterile procedures, they taught me how to do counts, things like that. And I think that's imperative. And one really slightly unusual area that it took us a while to identify that we needed support in was around communication. As radiographers, we're actually taught to not really say anything. So when you're a newly qualified and you're in A&E and you do that x-ray that might change someone's life, we're then told the report will be with you soon, or the doctor will see you in A&E, and we're not allowed, we're genuinely not allowed to say what we've seen on the x-ray because we're not qualified to do that. But then when you then take into my role, actually I have a duty now to follow duty of candour, to be very open, to be very honest, and to be able to communicate with families when something hasn't gone right. And they do say, don't they, if you haven't had anything to go wrong, you haven't done enough. So it happens to all of us that something will happen, a complication, be it minor or major, and I now am responsible for having that conversation. So one of our consultants has set up something called Better Conversations with us and the advanced practice team at GOSH, so that we can practice with the simulation team in the hospital and with some lucky volunteers. The sonographers normally end up being the mum in the situation, and she set that up, so we're training to have conversations with families and also with difficult members of staff, because you need anaesthetics teams to be on board. So we're building up to have an argument with an anaesthetist, I think, in the simulation scenarios, but we're going to get there. But that's something that we really identified, that actually it took us a while to realise that medical students have that training. They know how to speak to families when something unfavourable is happening, but we just hadn't had that experience. So that's one support system that I think is important. And the final support system I think is really important is each other. And that's why I wanted to set up the special interest group, because it's quite a lonely land sometimes when you're doing advanced practice if you don't know. And especially in interventional, there's a lot of networks already set up for plain film reporting, and that's the one that springs to mind. Whereas we didn't, I think there was lots of us doing stuff around the country, but we didn't know about each other. And actually having each other just to drop an email in, someone's on it today just asking, does anyone do these fluoride-guided pain injections, and sharing emails and things. And I just think that that's a really good support network and a really good system to have.
Excellent. So that's some really in-depth stuff about setting up and making sure you can sustain the service. I'd like to ask Chrissy, though, we heard about your vast amount of experience as a consultant. Going right back to sort of basics and getting job descriptions written for your advanced practice team, how important is that to set out in a job description exactly what's going to be required of the practitioners?
First off, thanks very much for having me. It's a real pleasure to be here. And one of the reasons I wanted to talk about the job description, particularly at the consultant level, is that we do try and standardise them, and they will be seen nationally. And if you can write a decent job description that goes out that we all look at, it really can be used to kind of judge the trust of where you're going to work to. So that's the first thing to say about it. Not only do I work in the NHS, I also work in the private sector, and I also review and look at job descriptions from around the UK. And you should be able to look at a job description, read it, get to the end of it and think, wow, what a great job. I know exactly what that person does. I know exactly what their level they're working at and what that delivers. It's a good way to evaluate job performance. So if you've got a job description, for example, as a reporting radiographer, it will say that you have attention to detail and that you can sit for prolonged periods of time and concentrate. Now, there are some people, as we know, that's not their skill set, is sitting and concentrating. So if you haven't got those skills, reporting radiography is not for you. But if that's outlined in the JD, that's where you can start. It's also very good to open the dialogue between managers and the person that's doing the job description. So what's been big for the three of us in Cornwall is actually writing our JDs. It's sitting with Jackie and getting it down on paper, agreeing that's what the service needs, and it's agreeing that's what we deliver. And that will be different for different trusts. And if you can both agree on that, that's where your starting point. Really, really important.
Excellent, thank you. I hope everybody's thinking of questions you can ask these people, because it'll be over to you shortly. But I'm going to ask Sarah another question, a little bit related to the one I asked Liz about the drivers. We've heard earlier on about the Richards Review and the recommendations to improve access to best available care. Along with the new faster diagnostic standards guidelines, how do you in Cornwall propose to accomplish this with the head and neck ultrasound service?
So we use, for 50% of our head and neck biopsies, we use a service called ROSE, which is Rapid On-Site Evaluation. So for those of you that don't know, when I do the FNA or the biopsy, we have a biomedical scientist in the room, and they can make sure I've got a sufficient sample, we've got adequate material, and that's really, really beneficial. It's increased first-time diagnosis from sort of 68% to 95%, so it alleviates patients having to come back and a delay in the diagnosis and the treatment, so that's really fantastic. We had to kind of look at ways of delivering this further afield, because Cornwall's a big county, and it's not practical to have a biomedical scientist in all the different peripheral sites. So we're trialling at the moment a thing called remote rows, so that's where we use telecytology. So we're out in a peripheral site, we do the FNA, and the cytologist who's at the base at Trelisk can view the slides and make sure we've got an adequate amount. So it's not been done in the UK before, and we're in early stages, but it's going really well, and it's really encouraging. Really beneficial to the patients, and also they don't have to travel so far, keeps them out of the acute hospital site, So
interesting parallels to the session just before lunch, talking about remote contact and using those technological systems. Excellent. Does anybody have a question as far as we've got? Anything to follow up on? I wanted to ask Chrissy, actually, there's quite a lot of talk out there about job plans for radiographers, job planning's been in place for donkey's years, obviously, in the medical community, but it's relatively new. It sounds like you develop particularly good and directional and detailed job descriptions. Where's the difference, and what's the difference for a job plan?
Yep. So the job plan is within the job description. So you've got the job description and you put the job plan. It's you can do it as a simple Monday to Friday if that's what you work and what you do. So we've all got job plans, and you put down what you're doing and when you're doing it. It can be quite broad because it has to be. I have these conversations. I'm part of a consultant review group across the AHPs, and people get het up with, oh my gosh, I've done, and Sarah's heavily clinical, but actually what you've got to accept is the level that you're working at, not the amount that you do. So you cross the 4 pillars with regards to your clinical, your research, and the other 2, and there may be some weeks. So at the minute I'm writing a chapter in a book, so that's taking up quite a lot of my time, which means for the next month I'll be doing less of the other, but overall that balances out.
Okay, excellent.
Have I answered the question?
Yeah. No, I'm probably not the only person here who wanted to know the difference, because as this bubbles up and more people are encouraged to develop job plans, what's that going to mean for us?
So the job plan is within the job description.
Yeah. And in your team, Steve, I'm going to ask you about how the advanced practitioner radiographers integrate, but does everybody have a similar planning process for how their job maps out?
Not at the moment, but I think that's something that we anticipate with consultant level practice, definitely, because consultant radiologists or consultants will generally have a job plan to work to. Obviously it has to be flexible for emergency work and the rest of it, but yeah, obviously there are fixed sessions within the week, but then demand takes over, and suddenly I think, if you lose your advanced practitioner on your list on a certain day because they're covering perimenemas and the other side of the hospital, it does have an impact. And I think to truly get an advanced practitioner to a consultant level, you have to work on the understanding that they're that they're not an optional part of the service. There has to be a point where I can step back and say that I'm here obviously for support in a remote capacity whilst I get on with something else. If you need me, I'm always here, but you can lead this list now. And I think that's something to look at with obviously we've heard about staffing levels and things this morning, but if you can try and protect those roles doing those activities, then obviously you can make someone essential to the service rather than just being a nice optional extra.
Excellent. Anybody wanting to follow up on that? Yes, so Susie's right here with her hand up. Keep it up for a second so that Rich can get down with his lollipop. There we are.
Hi, Susie White from Maidstone, Tunbridge Wells. I'm interested in the sustainability of this and how you've explored that, because at Maidstone, Tunbridge Wells, along with all of us, and what Sam was alluding to at the beginning of the day was about increasing radiologists and registrars in particular. And we find that we have some advanced practice radiographers and they're all set up to do things, but then more registrars come and they need their practice as well. And there can be this competition, really, that has, again, been alluded to. So have you managed to get round that in particular ways, or, again, with protected time, or what's your methodology to keep your practice going and also build that sustainability for the next generation of yous up there?
I have a small amount of experience. I work in quite a niche. Paediatric IR is a very niche area, and actually some of your colleagues at Maidstone Tunbridge have been very helpful to me. We've been in contact, and we find that the fellows, we get a lot of visiting fellows because we're so niche. We get someone's coming from Amsterdam, we get a lot of visiting people. But actually, it's about thinking of it in a different way, that we're not in competition. I am the longevity. I will stay there for the foreseeable future. So I am important to keep some of the time for, but then in turn, by putting time into me, I can now train them. So I'm not teaching them the most complex, mind-blowing procedures, but I can put a Hickman line in and I can show them how to put a Hickman line in a paediatric safely. And so by the consultants signing me off and saying that I am competent to do this independently, they're kind of by proxy saying, well, you can also teach one, which is kind of an old age saying in the medical world of like, watch one, do one, teach one, isn't it? So, you know, I wouldn't teach them on a 2-kilo baby, but I would on a 12-year-old. So, you know, that's kind of how we've taken the approach of, gosh, of not trying not to see it as a competition and to see it as I can help their education.
Yeah, and I'd like to reiterate that. So I teach all our registrars paediatrics on the plain film, and the benefit of us is actually we're quite a safe space because we are radiographers, and you know, there is no stupid question for us. I think a lot of the time junior medical staff don't like to embarrass themselves in front of their fellow bosses or consultants, whereas with us, you know, it's this absolute simple concept of school is a safe space to learn, and that's where kids make mistakes. And it's the same with what we do. You know, you create a safe space for these registrars, they will learn and they will do well and become good consultants.
We heard about the Imperial situation where they've got, you know, more radiologists they can shake a stick at, but also some of the kind of downsides of that in terms of empowerment of the radiographers. And I don't think there is an easy answer, you know, if you've got a training commitment, but it sounds like actually putting everybody on a level playing field is part of the answer.
Yeah, I think in some respects, the job market as it is, I think some of the radiology trainees feel as though they've got carte blanche really to tailor their training as they like. And obviously there are basic competencies that they need to achieve in each area. But some trainees are just terrified of intervention. You know, they don't want to touch, you know, needles or patients. And I think if you've got a trainee like that coming along, that is your opportunity to then maximise the training for the radiographers who are interested, who want to do that kind of thing. And in a similar way to the radiology trainee being off on the European Working Time Directive, time off after their nights. You know, you have to seize these opportunities and maximise them and get the training in if you can. And after a short period of time, you end up in a position where, you know, this person that you've invested all this time and effort, no, hopefully not too much effort, but all this time training, they can then support the radiology registrars coming through. And I think it's really useful to have that title of a consultant radiographer, because you know, you want to be clear with the registrars in radiology that this person is working at that level and can give them training and support. So you then don't have the nasty situation potentially of a radiographer trying to supervise a trainee who won't take advice from them, which is obviously something that has to be avoided.
And we've gone, I mean, Sarah's phenomenal in what she does and has taught our registrars head and neck. We're now sharing an office, so I really wanted to create an MDT, and it was a bit of a fight actually, but we're there and we're all really happy in the fact that Sarah and I share an office with 2 consultants. I wanted to make 2 radiology as consultants, and I really wanted to make that happen because we have to get away from the hierarchy, and it works really well, because Jack is now a consultant but is still asking for Sarah's advice, and I'm in with an AI consultant because I'm trying to develop AI, and so just by making that small change of sharing an office, you create that MDT and you get rid of the hierarchy.
It's breaking barriers as well, isn't it?
It's brilliant, you know, we get on well.
Yeah.
Brilliant. Let's go back to Liz. We haven't heard from you for a bit, so I'm going to drop one in. I'm watching for. There are some hands, are there? I'm going to ask Liz, and then I'll come to you. Is that okay? Tell us what was the biggest hurdle. I mean, we've heard about sustainability. What was the biggest hurdle in terms of setting up the service for you?
So as most of you are aware, the cardiac CT lists are supervised by consultants traditionally because of the medicine, mainly around the medicines management. So we administer beta blocker to many patients and GTN, and that's very dependent on the patient, so there's not a set dose for the patient, and so we had to work around that red tape. We can't prescribe as diagnostic radiographers, and I'm smiling at Sue here. And so, you know, our framework to work under at the moment are patient group directions, which, as most of us know, aren't ideal and fit for practice. And we are trying to work away from them rather than add more to our work in practice. And so the biggest hurdle for us was around pharmacy and having those documents agreed. But NICE guidelines outline this when they talk about PGDs, and sometimes it's about addressing those barriers early on. And so for me, it was around engaging with pharmacy early so that they could see the safety of our service, because ultimately that is the obstacle that will be the challenge for them, is your service safe, and if you can't prove that, then they won't sign that document off. And so we work really hard on the governance structure and the workflow documents, and at the moment I'm working quite hard on our competency frameworks, and so that engagement with pharmacy is ongoing, and it's quite fluid, and so they signed our documents off, and within a year they were really happy to review the documents and make changes, because we audited our practice and they could see. And I think one other thing to mention is we were a team of 2, so we started off as 2 radiographers who were trained up and competent to run these lists, and I think for pharmacy that added a level of security that we weren't going to have 10 or 15 radiographers suddenly going off and administering a drug that we hadn't been administering before, and I think it added that level of security that we were a safe service. And so
Thank you. Brilliant. Sorry to keep you waiting. Shall we go to this question here?
Thanks. So my question is, I suppose we all recognize the importance of advanced clinical practice, and in my trust we have training posts to support that, and as we do have advanced clinical practitioners. I suppose the challenge that we have, and I suppose many others in this room would have, is how do you protect those training posts in the sense that you have high turnover rates, sickness, and these are the people that tend to get pulled back into sort of acquisition, as it were. And as well as if you are job planned, how do you go about protecting that? So if I'm down to report on a Monday and we have sickness, then I lose my day because I have to go and do acquisition. Are there any tricks for the adults on the panel here who can help guide me on that? Because it's a real struggle, and I think everyone's suffering with that problem at the moment.
Yeah, I'll answer that one. So 6 a.m. is when I report, because nobody's going to call me to go and take an x-ray then, and if you're not in the building when they need you, they can't call you. So you need to look at when you can, that your advanced bit is when you can actually do it. It's a 24/7 service, you know, so it doesn't have to be 9 to 5. So I haven't been 9 to 5 for years, and the way I sold it to Jackie is that we'll try it, and if it works, we stick with it. If it doesn't work, we change it. I now do the most plain film in Cornwall before all the radiologists, you know, and so it's about looking at the time of day as to when you're, you know, least going to be pulled, but when you're going to be most productive. And most of our jobs are not 9 to 5. So I've done every Sunday for the last 8 years. I've come off it now, and Jackie said yes. But you know, it was Sunday mornings is when I did the work. And so, when you are picking somebody to be an advanced practitioner, they will have to make sacrifices. For me, it's fine at 6 a.m. I enjoy that.
Can I add to that as well? Is very much similar, is I will now support urgent referrals, so I have a direct link with the chest pain nurses, and I can, working with my team leader obviously, just provide lists out of hours, so weekends and evenings for the cardiac patients. But the biggest thing for me, and the biggest driver for advanced practice, is about your end result. It's your patient, isn't it? So we all love to advance our roles, and it's amazing that I feel very privileged to be able to do that, and I'm sure my colleagues do, but actually if there's no service improvement at the end of the day, then what are you doing it for? And I think some of the barriers are overcome if you can show that huge benefit, because then you'll carve out that time. But I think, like Chrissy said, it's really important to, I think when you work at a level that we work at, to have that flexibility and know that you might need to make those sacrifices. But I think we're probably all sitting here because we're happy to do that.
I would counter it slightly not to cause an argument on stage, but I think that works really well for plain film reporting. But I think with my IR head on, sometimes a lot of advanced practice is focused on reporting type pictures because that's the largest component of radiographers. But I can't do my work unless there's a patient available. So actually, I think what has worked well for us is that the radiographer that is training is always the last resort. So if it comes down, like you said, if a patient is about to be cancelled because there is no radiographer to press the buttons, as it were, then that person will be pulled. But until that point, our management are very good at protecting that person. And that's actually what you need, strong management to help protect, I think, the people. Because that's, yes, if the service is, there's a fire and everybody's off sick, like COVID was a great example of that. One of my colleagues did get pulled for quite a long time to be a radiographer because everybody was off sick. And that makes sense because, like, you know, not to be cheesy, but the GOSH kind of motto is the child first and always. So yeah, the patient comes first, as it would in anybody's trust. So that's up to your manager. Actually, I think you need really strong management to be able to protect that time.
Thank you. And the question was about the training, isn't it? Where you need the one-to-one to develop that. Sarah, in ultrasound, I mean, this is another incident where you can't, unless you've got a patient that wants to have a scan at 3 o'clock in the morning, it's not going to happen out of hours much, is it? So how do you balance that? Because there's a huge shortage of sonographers. How do you encourage people, and the managers particularly, to sort of buy into this idea of let's take some people, take them out, advance their practice?
It's very difficult. I mean, at Royal Cornwall Hospital, certainly the radiologists in particular since COVID have been doing reduced ultrasound lists, so they do significantly less than they did pre-COVID. And great for sonographers because it opens up the opportunity for areas that they never had before, you know, sort of contrast and babies and pediatrics and advancing their practice, and it keeps it really interesting for them and you know, great for retention. But something kind of has to give, and it's a very difficult balance. So, you know, for us, obstetrics is a huge problem. You know, 60% of a sonographer's list is obstetrics, and it's their least favoured area of work. You know, so if we can find a way of sort of drawing in on things like the growth scans, which are sort of heavily protocoled and with less leeway to go wrong from, and maybe offer that to sort of a band 5 radiographer wanting to progress into a little bit of ultrasound. You know, why not? You know, cross the boundaries a little bit. Yeah.
Okay, yeah, interesting approach. There's a question over here in the middle.
Good afternoon. Can I just ask a little bit, changing the subject slightly, and talk about qualifications and core skills and knowledge? So we often talk about our advanced practice radiographers who tend to be band 7, and we have our consultant radiographers who are 8 Bs, possibly Cs. Is there a role for senior advanced practice where their focus is very much on the clinical skills that they have shown us through their clinical practice as advanced practitioners? And where do we stand in terms of the recommendations that are coming out as to who needs MSCs and PhDs?
Is anyone on the stage? I'm going to ask a microphone to go to someone in the audience who can answer that in a minute. But anyone on the stage got any comments on that?
I don't mind offering something, but please tell me if I don't answer the question. But from my perspective, from the cardiac CT service that we're developing, I'm not going to sit here and say we had the perfect project initiated, because we've gone back retrospectively and said what competencies do we need. So we kind of drew on more of our experience and shadowing of consultants. And to grow the team now, what I'm doing is working on the competency framework. But there's no national standards even for consultants about how we manage a cardiac patient. There's no guidance to say you give X amount of drugs. It's very much, and there's been literature and reviews out there to say there's lots of different standards across trusts. So actually, if our consultant body doesn't have a standard for that, for the service I'm talking about, it's very hard to think of a competency framework for the radiographer. But I'm very much working on that. But we think we're going to end up having almost a tiered system where we have radiographers, which will probably be band 6s that works supported, but the consultant is within the department. And then we have another level where it's still quite prescriptive of what they do. And then we have your higher level, which would probably be considered at a master's level, where it's very autonomous and they make patient decisions about patients and that pathway, and they'll probably communicate directly with the referrer. But I'm just setting that up for my trust. I'd love to engage with some fellow colleagues here about a national standard. I've communicated with several trusts over the last few years about cardiac CT, and their one question to me is, what's your standard, what's your training? And there isn't anything. So actually we've got a bit of a blank canvas of working together and developing that along with our colleagues in education and the society, and if we all collaborate, and I think this forum's a great time for us all to get together and network to make that collaboration. So I might not have answered your question, but hopefully it's been a little bit informative of where we are, and I don't know if colleagues have got.
Yeah, I think that's the most common question I get asked is, what course did you do? And there isn't one. So I did do a master's, I am master's level educated, and I think level 7 education is very important, because I think you need that level 7 education to be able to do the research pillar, if nothing else, that you have to be able to do evidence-based practice, to do audits, to be able to do all of that, to be able to look at the current literature. You need to have had that advanced training in academically. So I think the master's I'm really hoping that I don't have to do a PhD yet, because I've done quite a lot of exams. In reality though, I think that PhDs by themselves are a phenomenal amount of work. So I think that needs to be very closely looked at, that if you are asking someone that already has a lot of strings to their bows, clinically, leadership, they have education and they do research, do they have time to do a PhD? Is a big question, and I think that has a huge impact, I think, on what those decisions will be in the future, or possibly already are.
So some real sort of chicken and egg sort of answers there, you know, what comes first. There's a hand somewhere, I think.
Hi, I've been a trust educator, postgraduate educator for 8 years as a consultant. I'm interested to know at the Royal Cornwall whether your organisation has been able to show equality for nursing and AHP education with medical education in terms of consultants being given EPAs or educational PAs in their job plans to train a certain number of advanced nurse practitioners or whoever else we're talking about in this role. And is there inequality? And if you have got equality, how have you managed it? Because we're not quite getting that, because we don't get it with our non-training grade doctors, let alone with our nursing and AHP colleagues, I'd very much like to see that equality, and I'm wondering if you had an answer to that.
Do you have an answer? I mean, I can answer just from a cardiac perspective, hopefully, again, if I don't answer the question properly, but in fact, she might kill me for asking. We've got one of our managers here, and I think our consultants do get training time within their PAs, but it was very much driven by, I suppose, my drive really to improve our service. So we did have that support from the consultants, and they had that training time, but our how do you benchmark quality? That's one of the biggest questions, isn't it? And so what we worked out is our cardiac service was really successful, and we'd had feedback from external sources and AI companies that have worked with us as well. So we use our consultants' level of practice as our benchmark of quality, and that's what we audit against now all the time. I don't know whether I've answered your question directly, sorry.
About the fact that, trainee doctors from a consultant will get nationally will get 0.25 PA, a consultant will get 0.25 PA for every trainee that is under their educational supervision. Do the consultants get equivalent for their nursing and AHP, and therefore do you feel that actually you are treated second rate to a trainee medic, which isn't fair, which I would like to see equivalence in my organisation, but I'm struggling to do that?
Okay. Yeah, sorry, I didn't answer your question. I don't
So,
really.
Any comments on that? I suspect not, is the answer.
Yeah, I don't think so.
No, we don't. So that's the short answer. No, we don't get a PA. Do I feel hard done by? I don't, actually. But that's, it's the nuances of the trusts that you're working in, I think, will be different.
I think it's a national issue, and I wonder if an organisation as big as the Royal Cornwall and the Sheffield, big teaching hospitals, if we all bound together to make equality happen, that would be good for our AHP and nursing colleagues?
I think how we work is that innovation, because we've got quite a team of radiographers who really want to improve, that feeds off each other, and so unfortunately most of us have just put a lot of our own time into it, and that's what we do, and we've got to where we are because we've got that drive to do that personally. So.
And I guess we're progressing, aren't we? I mean, we're right out of time. Thank you so much for your questions, and thank you for agreeing. This is amazing, isn't it? That none of these people had the benefits of slides to look at or prompts, so please thank them for a brilliant discussion.